Good evening, everyone.
Good evening.
Good evening, sir. So, this is the 66th issue of our Enoch DigiConnect webinar series, and we are lucky to have a guest speaker, Dr. Kewal Krishna, who is Director of Heart Transplant LVAD program from Max Healthcare Institute, New Delhi, and he has gone abroad and he has joined live from Philadelphia. And our second learned speaker is Dr. Rajiv Jain, our own Vice President AUSD. May I request Dr. Jain sir, our President AUSD, to kindly give the welcome address.
Good evening, friends. I welcome you all to this 66th issue of our webinar. And today we have got two guest speakers, Dr. Kewal Krishan, a leading cardiac surgeon. He is joining directly, as Dr. Sandeep told, from Philadelphia. And our another speaker is Dr. Rajiv Jain, who is our Vice President. And both the topics are very important. And with these few words, I welcome you all to this program and hand over to Dr. Sandeep to proceed further.
Thank you, Dr. Jain sir. So today is the 66th issue of our Enoch DigiConnect webinar series, and as I told you, we have a learned speaker with us, two learned speakers with us, and first is our guest speaker, Dr. Kewal Krishna, who is Director of Heart Transplant and LVAD program, Cardiac Sciences and CTVS from Max Super Specialty Hospital, Saket. And our second speaker is Dr. Rajiv Jain, our Vice President of AUSD, and he is Senior Consultant Health in Indian Railways, New Delhi. Dr. Kewal sir, actually, we are all industrial physicians, and we are an association of doctors from various industries, various public sector undertakings, private corporates, and we are spread across India. And this association, we have been conducting this academic program for last 1.5 years since the start of this pandemic, and every week from Delhi branch, we are organizing this academic program so that we remain in connect with our members, and so that they also don't feel isolated, and a connect is there with learning from each other and from the learned faculties, which we are thankful that they spare their valuable time even from India, or whether they are abroad. So Dr. Kewal Krishna sir, for our all participants, Dr. Kewal Krishna's topic today is latest advances in advanced heart failure. Dr. Kewal Krishna is, as I told you, he's Director of Heart Transplant from Max Hospital, and he has done 4 years of advanced clinical fellowship at world's top hospitals, including Mayo Clinic, Rocher, USA, and Mount Sinai Medical Center, New York, USA. Dr. Kewal is one of the handful surgeons in India who are formally trained in all aspects of heart transplant. He was trained intensively in entire spectrum of ventricular assisted devices, including bridge to transplant, short-term and long-term devices, and destination therapy. Then he has a lot of awards to his credit, like numerous publications and chapters in international journals, and multiple presentations in international and national forums. And reviewer, he has been reviewer for many publications for international journals. So today, as a topic is the latest advances in advanced heart failure, we would like to listen from you, sir, the medical versus surgical options which are there available in this particular circumstances, then heart transplantation versus LVAD, then use of mechanical circulatory support devices, and how they are used in acute and chronic conditions, and the role of the team-based approach, and your experience with these sort of exigencies and treatments that we would like to learn from you, because we as industrial physicians, although we are not cardiologist or some specific physician specialize in some clinical specialty, but as a industrial physician, we have to be aware of the latest advances in every field of medical science, because as industrial physicians, we have a duty to support our management, to support our workers, and guide them for the proper treatment. And if we are aware of the things, then only we can give any support or any advice to our workers or to our management. With this, sir, Dr. Kewal, the floor is yours, sir. We are thankful that you have spared your time from Philadelphia, and the floor is yours. So you can share your screen. And
so I'm grateful to everyone, and today I'm gonna speak on latest advances in advanced heart failure, artificial hearts, and heart transplant. I'm grateful to your DisyCon and all the members who are organizing this. And my message is to basically, I'm going to send you a message which says what is left after end stage heart failure. A lot of people, if you see in 70s, 80s, the quality of life and the survival was in India, it was only 53 to 55 year of age. Now people are with CABGs and all these things, they're living to 70s. So our purpose is to make the life is longer, so that we can increase the life expectancy further 10 to 20 years, like 70 to 80 or 70 to 90 years. See, the burden of heart failure is a lot in this country. And if you see, a lot of patients are dying because of heart failure. Death of heart is basically the death of the patient. And it's a different from the this onco problems, the cancer problems, where we don't have treatment. In advanced heart failure, we have the treatment. If your heart fails, either we can do heart transplant or we can put an artificial heart. And the another problem is, when you have a heart failure, your patient goes to the hospital, 3 more attendants also, they go to the hospital. So 4 people are not working, and it is actually a financial burden on the society. To reduce the financial burden, it's also important that the patient who is there should be working, so that the other members will also be working. It will reduce the financial load on the society actually, and improve the society's condition. So progressive, and because heart failure is a progressive and complex disease, high burden, and healthcare system and individuals and multidisciplinary teams is involved. MCS has proven to record better survival and patients' quality of life, which I'm going to show you later. The acute the acute heart failure is, we have a lot of options: artificial heart, left side, right side, both sides, ECMO, with this support, bridge to decision and bridge to transplantation. And the HeartMate 2 and HeartMate 3 are the most commonly used devices in the world. So HeartMate 2 came in 2004, and by 2006 it became one of the great option for those patients, those who were dying because of the heart failure, and it gave almost 10 to 15 years increased the survival. So after that, the HeartMate 3 came, which actually increased a meaningful innovation with least complications and better survival. So this has increased the quality, not only the quality of life, but also the survival of the patient. And it's the most advanced technique. So, and if you see, there are almost 27,000 patients implanted on HeartMate 2, and there are almost 20,000 patients on HeartMate 3. Need for the center to establish is to complete. You have a heart failure solutions, identify core team. Because it's a complex issues, so you need to have a trained team, set protocol, set infrastructure, social and financial support, because these are costly affair, and you need a competent team to do it. Training and education of the team is very important with the expert people, because it's a heart, and if you lose any opportunity to treat that, the patient will die. So the treatment before 2010 used to be, we used to give a lenoxin with the whip the horse, unload with the Lasix, or slow the horse with the Ivabred in the beta blockers. But nowadays the solutions are get a new horse, means do a heart transplant, get a new tractor, means put a ventricular assist device, or heal the horse with mitra clip or everything else. So the new treatments which we are going to talk about is today is a heart transplant and ventricular assist devices. So if you see, the heart failure treatment used to be lenoxin, Lasix, and then lisinopril and other AC inhibitors and beta blockers. And now the Vimada and the Sidmus, they have come as a ARNI and medical therapy. They have improved survival to an extent. And then ICD is basically used to prevent the sudden cardiac death. If the patient has a heart failure and end stage heart failure, heart is usually gets dilated. Ejection fraction is 20%, 30%, or 15%. They usually get dilated. And there can be anywhere short circuiting that leads to ventricular fibrillation, which is taken care of by the ICD. ICD does not improve the cardiac function, but it prevents the sudden cardiac death. CRT is basically, there are two pacing wires in there are total three, uh, two pacing wires in the two different ventricles to contract them uh, and simultaneously, so that it's a resynchronization therapy basically. It so that the cardiac output can be improved 5%, 10%, and this. But as the heart failure is a very complex and progressive disease, the ventricles keeps on getting dilated, and after 4 or 5 years CRT also doesn't work. Then the treatment, the final definitive treatment which comes is heart transplant and ventricular assist devices. So the classification of heart failure, there are A, B, C, D by the medical people, and by the surgeons is intermax. So we are going to talk about only the advanced heart failure, the refractory, that's a stage D, refractory heart failure requiring specialized intervention. Intermax is basically, as a NYHA4 has been further divided into six, because NYHA4 is a very big and broad terminology. The Intermax 1 is crash and burn situation, 2 is sliding fast, 3 is stable on inotropes. The 1 and 2 require immediate attention to put a short-term circulatory support. 3 and 4, they actually requires either LVAD or heart transplant, and 5 and 6 can be on the transplant list. If they go up on the list, can be we can put the ventricular assist device, because ventricular assist device does not require any waiting time. The drugs, as I mentioned to you, the Sidmus and Vimada, they have come and they are improving survival to an extent. We are giving patients home milrinone and home dobutamine therapy, because these patients are keep on coming in and out of the hospital. You don't want them to be in the hospital again and again coming. So we can give a home milrinone. It used to be only in the hospital on syringe pump, but now we have pumps available. You can, it's only 2,500 rupees pump. It's not very costly, and patient can be on this pump for like 6 months, 8 months. It does not guarantee that patient will not come, but it will definitely reduce the number of, if the patient is coming in like in 6 months, the patient is coming 4 or 5 times to the hospital, he will come only once. So, and it also reduces the pulmonary vascular resistance, the lung pressure. So the breathlessness will be less. It could be milrinone or dobutamine home therapy. And we give to a lot of patients. And we have seen those patients they came for transplant workup. And because of high pulmonary vascular resistance, heart transplant was contraindicated. We gave them 6 months and 4 months of dobutamine milrinone therapies, and the PVR, the pulmonary vascular resistance, it came down and patient became eligible for heart transplant. The another thing which I have already mentioned, the ICD has a one single wire. It's only for the shock in the ventricular fibrillation, and a CRTD has 3 wires in different chambers, and it makes the contraction at the simultaneously left and right ventricle to improve the cardiac output. If the patient is timely referred to us, like the patient is in Intermax 4 or Intermax 5, then the survival is much better than if the patient comes to you in Intermax 1 or 2. Means the patient comes to you a very critical, the chances of survival are less than if the patient comes unstable or with resting symptoms or exertion intolerance. So most of the physicians, they know about the IABP, this balloon pump, and it's being used everywhere in the country. So most of the cardiac centers are using, and cardiology people are also using it. It supports only 15% of the cardiac output. Tandem heart and Impella, they support 30 to 60%. The devices which I'm going to tell you in next few minutes, they support 100% of the cardiac output, whether it's a CentriMag, HeartMate 2, HeartMate 3. And ECMO supports lungs also, but that's an extracorporeal support. It remains, or it can be kept only for few weeks to few months. So if your ventricle is very big, burned out ventricle, there's whatever you do is not going to work. Either the patient keeps on coming to a hospital, or the patient would die with a sudden death. So heart transplantation, ventricular assist device, and total artificial heart are the options for these patients. Those patients who come to you in a critical shock or critical condition, the ECMO, like the CentriMag, can be made as a ECMO by putting oxygenator in the circuit. So it can be used as a either bridge to recovery, like the patient with the myocarditis. If the patient is gonna, you know that 4 to 6 weeks, the heart function is gonna low, and then it will improve. So you can keep the patient on ECMO for 4 to 6 weeks, and then patient recovers, and you send the patient home. Or bridge to decision, when the patient comes in a critical cardiogenic shock and you don't, the high lactate, blood pressure is low, you cannot put a costly device because it takes longer time and the cost is very high. The short-term devices like CentriMag or the the ECMO system, they can be put immediately to save the patient, and then you can think of either bridge to another bridge, means a permanent ventricular assist device, or heart transplantation. This is the device which I was talking about. This is the most commonly used everywhere in the world, because it's fully magnetically levitated centrifugal pump which works as a right ventricular assist device, left ventricular assist device, biventricular assist device, or as an ECMO, which was being used in these COVID times. So there are different kinds of durable devices are available. HeartMate 2 and HeartMate 3 are being most commonly used devices so far. HeartMate 2 is an axial flow pump, and HeartMate 3 is a fully magnetically levitated pump. This is how it looks like in the body. We connect the pump inflow cannula to the ventricular apex, and pump gives blood, and it goes to the aorta. So whatever blood is coming into the left ventricle, it's going into the aorta. So it's functioning as a left ventricular assist device. So I'll show you how and its global footprint available, like it's everywhere in the world. And how the device works: when your ejection fraction is 15%, 20%, your high CVP, high pulmonary pressures, and your forward flow is less. When you put a ventricular assist device, heart gets relaxed and your forward flow increases. Backward pressures, they go low, forward flow increases to like from 2 liter to 5 liters. So your ischemic liver, ischemic kidney, they start getting more blood and patient becomes clinically normal. This is how the device works. And this is how the device works as a technical. When it's connected to the ventricle, the impeller rotates and it gives almost 5 to 7 liters of flow. And when your ejection fraction is 15%, 20%, it cannot eject enough blood according to the requirement of the body. Then this device works as your almost 4 to 5 liters of flow. HeartMate 3 is a fully magnetically levitated technology. But it's intrapericardial. It has least possible complication and more benefits to the patient. At this present, this is the most advanced, not only most advanced, most commonly used device in the world. And the flow limits are from 2.5 liters to 10 liters. So the range is very, you can small body surface area to very large body surface area, you can use it. And because it's biocompatible, and blood path is textured surface, so it's less and more hemocompatible also, and minimize shear stress and trauma to the body. So these patients, they are on device for 5 years, 6 years, 8 years, nothing goes wrong. So we have a lot of patients for 5 years, 6 years, 7 years on the device. The result of Momentum 3 has shown highest survival rates for any ventricular assist device, and lowest hemocompatibility related adverse event like thrombosis of the device or any immediate significant sustained improvement in the quality of life is there with this device, least possible stroke rate. So if you see, this is the lowest, 1% only thrombosis, 10% stroke rate. It's very less. And that this, I used to believe even 10 years ago that there is something is going to come which will replace the heart transplant. And if you see now, the HeartMate 3 has shown almost similar results to heart transplant with the improved physician care and improved technology. Basically, both are very contributory to this. The another device, when you have a biventricular failure, you can use either two ventricular assist device, left and right, or you can use Syncardia total artificial heart. Our experience of this device is like we have a separate ICU for ventricular assist device transplant, and if you see nitric oxide load, the left ventricle is monitored by the left assist device, and right ventricle is monitored by the SWAN, continuous SWAN cardiac output. So you need, so the two ventricles are now, one is your native ventricle and another is your mechanical ventricle. So it's a, you need to be taking, you are now controlling the heart by all means. So these are few patients which I'm going to show you. They are enjoying their life on device. India's first HeartMate 3 was put by us, and he's doing really fine. The another lady, she celebrates her birthday every year of the day of surgery. And this guy is a very phenomenal improvement. His ejection fraction was 15%. He was married to one lady, and now now he had 3 wives. So it's been a lot of, and he sent another guy after 1 year who is 40, he was 42-year-old, and he could not get married because of low ejection fraction. And we put a device on January 2020, and in June, during lockdown period, he got married in his own country. This guy is he's a mechanic from Kazakhstan, and he's really doing fine. This one photo is 1 year post LVAD, and another photo he recently sent 2 weeks ago to me. The another lady, see, there is no limitation like in heart transplant. You don't do heart transplant after the age of 65. But with LVAD, you can do even at 90 years. So this lady is the son is standing. He's a physician in the Germany, and he brought his mother for ventricular assist device. We put in 2018, and she has come last week for the follow-up on after 3 years. So she's been doing really fine since then, and age is no bar. And the another is one 7-year-old girl. We put a ventricular assist device on 4th of December, and this video is of 6th of January, after 1 month in her own country. And the another guy, he's one of the member of parliament for Congress, and he was from UP, and he is doing fine. So there are 2 critical cases. I'll let you know when these, see, you should not be sending patient in that time because you can send before that. But I'm explaining you about how the patient, 38-year-old gentleman with cardiomyopathy, AICD for the last 2 years, admitted to another hospital on ventilator, pulmonary edema, and multi-organ failure. He was told that he would die in next 2 hours, and we were called to put an extracorporeal VAD and transfer to our hospital. We started a lot of things on this, and patient was brought to our hospital at 2 a.m. and the labs at 2 a.m. are TLC 24,000, creatinine 7.8, urea 272, and liver enzymes were in like 8,000, 6,000. Neurological status wasn't known. After we started on CRRT, and 2 days he woke up. After 2 days he woke up. Esmolol infusion was there for a long time. So because of paucity of organ donation, LVAD looked to us more appropriate option. So this was his ventricle at the time of admission. This patient, we tried to wean inotrope, remove the IABP, but the patient again crashed. We reintubated and put IABP again. I mean to say the patient could not even tolerated for the this 3 hours also. The LVAD was implanted in 2015, and he's been doing fine. And these are the parameters post LVAD, as the pump flow, the cardiac output, which was 2.4 liter before surgery, and now it's 5.6 liters. This is a CT autogram. It looks how the device is placed in the heart, and your outflow graft is not kinked, the drive line is not kinked, and this is how it looks like. A volume rendering image. And this guy, we used to send him to the cafeteria to just get used to without the patient, without the nursing or doctors, for 3-4 days, and then he was sent home. We usually trained the family to take care of the VAD, and they become master in few days. And after 1 year post LVAD, he was getting an award. He's a counselor for the students, those who go abroad. Another guy, 46-year-old gentleman with extensive MI, and he was in another hospital. PTSD was tried. He was put on a VA ECMO. We shifted the patient to our hospital. We also, the ejection fraction was 10%. We tried 3 times to wean the ECMO, but we could not wean the ECMO because below 1.5 liters. So we had to put a ventricular assist device. And he's after 22 days on ECMO. HeartMate 3 was implanted in March 2020. I met him 2 days ago in Jaipur. He's really doing fine. The points of discussions are basically approximately 85% of the LVAD patient are implanted in Intermex 1 to 3. If these patients come earlier, the results can even be better. 5 to 10% of the they are in Intermex 1, almost crashing patients. So my request is to send this patient a little bit earlier so that results can be made better. The aim of good outcome with the least events is background assessment, prevention, and management. Post-op challenges which we see in such kind of patients is vascular complication, bleeding, infection, neurological. These patients they have cardiac cachexia, so they are very frail, and altered anticoagulation maybe because of ECMO or back pressure, increased back pressure changes liver failure, and kidney failure leads to high creatinine and high urea. To prevent the complications, minimum surgical time, minimum possible extracorporeal time, and we use filter, cytosol, endotoxin filter, and early decision if RVAD is required, meticulous hemostasis, and prophylactic medications. So the main problems post-operative are bleeding, infection, right heart failure, and if the infection, we usually treat with the cytosol and other leukocyte filters, and nutrition and physiotherapy are the key after because they are very frail, and they have been to multiple hospital, multiple doctors, and they are in cardiac cachexia most of the times. This is the cytosol filter which we use to if the patient has a high cytokines, which was also being used in the COVID times to reduce the cytokine loads. And if you go to my paper in Indian Journal, I have wrote in detail about the cytosol. So most of the people ask me the advantage of ventricular assist device over heart transplant. That's why I made one slide that, or after the age of 65, we usually don't do heart transplant because we take the immunosuppression, we can damage the kidney and liver. Ventricular assist device does not have any limitation because of age. We have done 2 octogenarians above the age of 80, and I have seen 89-year-old female. After 3 years, she was 92, which was shown in one of our international meetings. So, and high pulmonary vascular resistance, when it's a pulmonary vascular resistance, lungs are very bad, then heart transplant may not work because your right ventricle may fail, but a ventricular assist device is an option. High susceptibility to infection and rejection, like those patients like active tuberculosis, or they have a high PRAs, that more chances of rejection than you can do a ventricular assist device. Patient of 120 kg, you will not find similar kind of donors, and device you don't have to be like for heart transplant. We usually say 1 month, 2 months, 3 months, sometimes 6 months in corona time. So for ventricular assist device, there is no waiting list. Heart transplant is basically as a cardiogenic shock. All the indications of heart transplant are basically end-stage heart failure. when your heart is not able to maintain the cardiac output. So this is a small video which I'm going to show you. This tells you how the heart transplant is done. So as it's a 2 minutes video, you will like this, how it works. So this is how the transplant is done, and we usually give immunosuppression, tacrolimus or cyclosporin, mycophenolate, prednisolone, and statins. And we identify the allograft rejection is most commonly by the the half-life after transplant is close to 14 years basically. And the 95% of the patient, they have no activity limitation, 4% they require some assistance, and 1% they require total assistance. And the another thing is ECMO, which is being most commonly used, and it actually got a lot of known as work in this COVID times. We saved a lot of patients on ECMO. Indications are basically cardiac, respiratory, and cardiorespiratory. Either your heart, lung, or it's when the COVID, this is a COVID lung, when you see the X-ray, it's completely white. So when the patient goes from oxygen and to a nasal oxygen, and then to a BiPAP, and then to a intubation. But in all these measures, every time the lungs are being used. If your lungs are completely screwed up, completely damaged, then you have to find another way to give oxygenation and remove CO2, and that is ECMO. So if you see these COVID lungs, these are the already damaged lung. The patient cannot maintain oxygen saturation despite 100% support on ventilator. So we put patients on VV ECMO for the lungs and VA ECMO for heart and lungs. So we take out 5 liters of blood, oxygenate, remove CO2, and put it back. So this is how venous ECMO looks like. We put a cannula into the groin and one in the neck, and the blood is deoxygenated blood is taken out, oxygenate, and put it back. So this is how the circuit looks like, pump and oxygenator. And this CentriMag can be made as, if you put an oxygenator in the circuit, it can be made as ECMO. It's one of the good options to make it an ECMO. And this is how it looks like. It's a versatile RVAD, LVAD, or ECMO device. So it can be used in the post-cardiotomy failure, right ventricular or left ventricular, or after LVAD, your right ventricle is not working. When myocarditis, I mentioned to you, those bridge to recovery or post-infarct shock or post-MI-VSTs and all mechanical complication, you can use it. These devices are basically rescue therapy and meant to be put in a dying patient, not the dead, like the patient is lactate is 16, BP is 40, it will not help, but it has to be a bit earlier than. The key to success of short-term device is basically time of initiation. This is how that was veno-venous. This is veno-arterial, one cannula into the femoral artery, another in the femoral vein. And this is how it looks like bedside, how we put it. Take out 5 liters of blood, oxygenate, and also heart function. And this is how the X-ray looks like. Carotid cannulation was also being used, but nowadays it's not done because of the stroke rate. And as soon as you put the patient on ECMO, within a minute, the saturation comes up to 96, 98, 100%. Your heart rates get stable, your blood pressure goes up, your all inotrope going 25 of norepi, 30 of epi, dopamine, dobutamine. They are weaned off within 4 to 6 hours. And if the patient's urine output is dropping or like 10 ml, it starts improving after that. We have done a lot of ECMO. Some patients recover in 20 days, 30 days, and this is I think the longest survival in the country, because I have seen so far heard of 72 days. This patient post recovery was 75 days on after ECMO post COVID, and he's doing really fine, about to be discharged. We usually bring patients from another hospital in Delhi or from another city like Ludhiana or elsewhere. And we bring the patients from another countries also, like Middle East, from Nepal. We shift the patient we go over there, put the ECMO and bring to our hospital. So ECMO retrieval in the city, outside the city, in the country, and outside the country is also possible. This is how we usually bring the patient in ambulance or in aircraft. I am also principal investigator for one of the ventricular assist device, and for which I'm here in Philadelphia. So thank you very much for listening to me, and I'm grateful to you. If you have any questions regarding heart transplant, ventricular assist device, lung transplant, or to the ECMO, like in COVID time, it was being commonly used. So or you can go to my website, kewalkrishan.com. For more information, you can ask me or you can visit my website. Thank you very much for listening to me. And I am happy to have any questions, more than happy to answer those.
Thank you, Dr. Kewal, sir.
Yeah.
This was really an eye-opening presentation by you, in which we learned a lot about the latest techniques which are available for saving the lives of the people and for improving the quality of the life of the people. And especially during this COVID times, how this ECMO has saved the lives and how all these devices, they work. You have very nicely explained all these things. And now may I request all the panelists, if they have any question, they can just raise their hands and they can ask directly from Dr. Gajen Kumar, sir.
First of all, I compliment Dr. Kewal Krishan for a wonderful presentation on this subject. My question is, what is the finally survival rate among the heart transplant patient, number one? And is there any such cases reported where both heart and lung both are transplanted in a patient?
Yes. Heart transplant, first year survival is 95%, and 5-year survival is 70%. So if we operate 100 patients, 70 will survive by 5 years. For heart and lung transplant, it used to be done very commonly, like 450 transplant a year, across the globe. But now it's being done only 40 or 30. The reason is when you do a heart and lung transplant, it's 2 lungs and 1 heart. You are replacing 3 organs, transplanting 3 organs. So chances of infection and rejection are very common in any of the organ. So even if you do a 1 organ like heart, there are chances of infection and rejection. If you are replacing 3 organs, the chances of infection and rejection are more. So now the ventricular assist device, which they have reduced it to from 90% is taken care by the ventricular assist device, because heart and lung was only done when the heart, if you replace the heart, it's not going to work because lung pressure was high. Now, LVAD can take care of that pulmonary vascular resistance, which I mentioned. That even if now actually for the LVAD, there is another indication which is called bridge to candidacy. Even if you want to go for heart transplant and you are not eligible to go for heart transplant, or you have an indication to heart and lung transplant, you put a ventricular assist device. The pulmonary vascular resistance goes down within 18 months to 22 months or 24 months, 1 to 2 years, and then you can do heart transplant if you want to. So,
Okay. Right. Thank
so
you.
it has remarkably reduced the incidence of heart and lung transplant, because when you're replacing 3 organs, chances of infection and rejection they are very high. So,
Dr. Kewal, there's one question from me that yes, these new techniques, they are available and they are quite helpful to the patients who are in need of them, but they come at a cost. So
yeah.
what is the approximate cost expenditure for implanting an LVAD?
So for the HeartMate 2, it's close to 45 to 50 lakhs. And for HeartMate 3, it's 90 lakhs.
Okay.
Including the cost of device and surgery.
Okay.
And 20 days stay, in the hospital.
Right. Dr. Pawan, you have some question?
Thank you so much, Dr. Sharma. Yes, you are saying something, Dr. Krishan, please.
Yeah.
Yeah,
See,
I just wanted to.
Just
it looks very,
madam, one by one, please.
for now, it looks very, it's like 90 lakhs or 50, but the patient, those who are like one patient, I'll tell you, one patient was in another big hospitals of Delhi, and he was almost, his cremation was decided, and the family asked, is there any other option? Then the doctor, cardiologist, he was a very intelligent person, and told that if you can spend 90 lakhs, then I can give you the option. The patient was shifted to Max, the first HeartMate 3, which I told you. And now this patient is on the device for like 7.5 years. And I probably, if he lives for like 10 years or 15 years, for those patients, those can afford, it's 1 crore is nothing for them, because nowadays it's very less amount, I would say, for 1 crore. People don't want to spend even for the consultation fee of 500 to the doctors, and they can spend a lot of money in all the recreational activities. But they should understand, like, even if the patients, those who survived on ECMO in COVID times, they usually, the ECMO was removed in 30 days, 45 days, 70 days. Most of the patients, the bill was close to 50 lakh, 70 lakh, 80 lakh. So, but they could make it. If you don't have, you can't afford that, you will lose the life, because life is more important than this money.
Dr. Manju
Yes,
Bala, Dr. Manju Bala, she is.
Okay.
Yeah.
So I just wanted to thank you, Dr. Sharma. I had something in my mind and wanted to check with Dr.
Madam,
Krishan.
just 1 minute. Anyway,
I was just traveling. That's why I just joined in. And I wanted to ask Dr. Kewal that we had our one doctor who we lost him due to COVID, and he was kept on ECMO before for preparing for lung transplant. But when he was there on ECMO, I think just within a week only he expired. He could not survive.
So there are multiple reasons the patient could not make even on ECMO. One reason is they developed pulmonary embolism. And even the patient, we do a lot of awake ECMO, like patient is not on ventilator, patient is on ECMO and enjoying he's eating well, he's doing exercise, but his lungs are not working, so the patient is on ECMO, you cannot win. So these patients we have seen, there's a lot of, the big clot goes into the pulmonary artery, blocks the heart, and the patient dies. Another reason is, if the patient is younger, like 30, it was 30 or in 30s or 40s, most of the patients, they have cytokine storms every second or third day. And when you have a cytokine storms, in the COVID times, they usually, what happens with those patients, they behave like a septic patient. All the parameters which we see in the sepsis, interleukins and D dimers and all this, and they increase in that. So it behaves like a severe sepsis. and we could not save patients because of this. Like when it was we used to put the ECMO for bacterial or viral pneumonia, the survival was 70%. With swine flu, it came down to 50%. With COVID, it was only 10% survival. So it's, and particularly for the younger age, if you are above 50, chances are still better to come out, but below 50, like 45, 42, 36-year-old, its survivals are very bad.
Yeah. What Dr. Manju was referring to, that patient, actually he was hospitalized for a long time, and after that only that ECMO was advised as a bridge to lung transplant. So might
Yeah, could be because of frailty and infection or something else. Or I have seen even after 40 days on ECMO patient, they had some cytokine storm. So, or could be ICU related or patient related factors could be one of the reasons to that they cannot make it. So,
yeah. Okay.
Thank you, doctor.
Thank you,
Thank you.
Dr. Manju madam. Dr. Pawan Gupta. Please.
Yeah. Thank you so much, Dr. Sharma, once again. And first and foremost, many
Thank you.
congratulations, Dr. Kishan, for deliberating on this subject. We are really thankful to you for spending your time. My query is related to uh, uh, enabling or maybe capacity building of the public healthcare facilities of these kind of innovative approaches. So what is your opinion and perspective on capacity building of public healthcare facilities, and are they doing enough, or are we moving towards it? What are your thoughts?
see, when I came to this country, India, after got training in US for this all this stuff, people, even the highest profile cardiologist and cardiacs, they didn't believe this, that this is going to happen. They used to ask me, people don't give 2.5 lakh for coronary bypass surgery, how will they pay for 90 lakhs?
Correct.
One financial constraint, and another is how would they believe that's a 90 lakh surgery? So family is very, so, but when we started this, we started with few patients, those who cannot make it. If you don't do, they would die in day or two. So they paid and they actually made it, and then they were doing really good, and then they encouraged other patients. So it kept on happening, and few patients from other countries. We have a lot of medical tourism in Delhi also.
Yes.
A lot of international patients also came for this. See, if I go to your question, that we need to develop a system, like a lot of like people after a second wave, a lot of companies are actually coming to us and asking me that what should be the ECMO, or related to questions like ECMO. They want to give privilege to their all the employees about regarding the ECMO. Because it was not like there were only 2-3 centers in the country. Like one, we have done so far 368. So I'm doing for the last 7 years. So there are 2-3 centers in the country which are actually, they were actually doing. But now in COVID times, most of the centers they are doing, even small or big centers. So, and these, even the people, common people have come to know that if your lungs are not working on ventilator and patient cannot maintain saturation, the next option is, it's not the final option, but few patients can be saved on ECMO. So now companies are giving they're asking a lot of questions. What would be the package? What is it? So there's awareness is increasing about this. But it's on the way, I would say. It's an initial.
Yeah.
So the same thing will happen, like when you come to know that your family member or yourself or somebody else in your family, if you can afford, you would like to live for, even if I say you would live on Elvet, probably instead of 15, I would say you're going to live for 9 years, 10 years. Still, it is nobody would like to die on, so it's going to be coming. So I'm also developing one van, and that is why I'm here in US now for the patent government. It could be way cheaper to available to India. So
I wish you all the luck for your hard endeavors, Dr. Kishan, and we look forward that it is available to masses in India. That's the biggest challenge India has, public healthcare facilities, empowerment of the same. Thank you so much. Thank you.
Dr. Kewal, in this regard, I would suggest that we should also, because we are all from some corporates or some public sector undertakings, Like
Yes.
Dr. Manju Bala is from, she's head of the ONGC Medical Services.
Yeah.
I'm from Indian Oil Corporation, and many other friends, they are from different corporates and railways. So we should formulate some guidelines, that what are the guidelines in which in this particular case, LVAD is required, in this particularly heart transplant is required, because we, in this regard, I don't think we have got Indian guidelines or some common.
No, that we can make it, and we can give to your respective ministries or respective heads, or
We will,
the IAS, your secretaries, so that the people can see these things should be, see, everyone nowadays, the quality of life has to be really good. People believe that, oh, 90 lakh rupees, but if you think, like, that if you have a heart problem and stage heart failure, one, that this is going to be, patient would die if you don't do a right treatment, the definitive treatment. Another thing is, as I mentioned to you, 2-3 family members are also get engaged with that person.
Correct.
Yeah. So if that person is working on LVAD, and the other 3 members will be also free of that. See, one patient we operated, they went to 13 countries. So you can see that level of enjoyment they have. Yeah. And I showed you a few patients. He is in embassy from Kazakhstan. He was a mechanical, and then he entered into, he was working in embassy. They could give him permission for such amount of money, but people are enjoying their life. It's really good to have, and changing a battery, and it looks like a complex, but it's a, I usually compare with a cell phone. Like, if you buy a new cell phone, for first 3 days you will be looking at what I have got, and after that you become master of that, and you are actually the master of that particular instrument. Same thing happen in LVAD. For 4 or 5 days it looks to you what is battery, what is controller, and then most of the patients tell me that I am doing this. So that's okay. And the best part is, you don't have to be managing, like the patients in Middle East, Saudi Arabia, the other place. I tell them, you come to India, just show me after like 2 years, 3 years, 4 years. They are on with me on WhatsApp. But they don't want to come. They say, if we have problem, we'll come. So you can think, there's no dependency of surgeons and nurses on the ward, particularly with HeartMate 3.
Okay, sir. Now the last question from Dr. Tyagraj. He's from Bangalore, very senior member. He has raised his hand. Dr. Tyagraj, sir. Yeah, you can unmute yourself. Yeah.
Thank you very much, Dr. Sharma ji. Dr. Kewal Sharma ji, your speech is one of the best speech, and it is really a benchmark and roadmap to all of us. One of the best and the wonderful this one. We were thinking that after ECMO, in the COVID second wave, we used to think of only lung transplantation, or if there is anything, is an heart transplantation. But HeartMate 2, HeartMate 3, so many devices you have shown, which is really an enlightening, and it is very good. Even after age of 60, you said that cardiac transplantation is not a good method, but people has to go for this one, HeartMate 3, or this one, even 90 years you have shown. Really, it's a great, we have learned a lot from your beautiful lecture. Thank you very much, sir.
You will have a good part that even after the age of 70 or 80, if you get, even if you are somebody, like most of the patients, they go for bypass after 55 or 60, which is the most common age for bypass surgery. And after 13 or 15 years, your coronaries are all gone, your heart function is poor. So now what is the option? People used to believe, oh, my heart surgery is done now, this is the last chance I could be. But now you have hope. Even if your heart is not working, we have the means to work it for many years. Yeah. So it's
thank you very much. Yeah. And really, one thing I just wanted to inform you now, the insurance people, before COVID 2, they were doing for only 5 lakhs to 6 lakhs. Now the insurance premium and the insurance maximum, they have raised to 30 lakhs for people who are between 30 and 35. They are offering 35 lakhs insurance for after COVID 2. It's a really a great, because once insurance is there, people can afford to go to the big
Yeah.
hospitals and get it done. This one, thank you very much, sir. You have enlightened us. It is a really roadmap and benchmark to all of us. We have known a few of the new things. Thank you, sir. We can refer to some of the patients to this kind of this one, because we were not actually, to be frank with you, we were not knowing all these things are there. We were only thinking of long term.
Yeah, I've been doing this for the last 7-8 years in the country. So to 2015,
Yeah.
14, 15, I came to this India.
Thank you for our Dr. Sharma, who is a moderator and who is an All India Honorable General Secretary. He is really helping us by showing some, enlightening us with very good topics. Thank you, sir. Thank you very much.
Thank you, Dr. Tyagaraja, sir. So with this, sir, Dr. Kewal Krishna, we thank you very much, and we wish you you come back. When you come back, we'll have a great discussion, and we'll formulate certain guidelines for our.
Yeah, I think this is with this meeting. I think we should sit together or through a Zoom.
Yeah.
We can make guidelines for the country that
What are the
if
indications?
this problem, yeah, like the international they make, like
Yeah.
in USA there are guidelines there. And
So
I am
what-
president of the Indian Society, also president for Indian Society for Heart and Lung Transplant.
So if these
yeah,
guidelines, they are coming from some authentic sources, then they are really they are useful, and they will be they are much more acceptable by
yeah,
the.
I can give you the US guidelines. We can make it according to, we can change it to according to Indian stuff. It's not a big deal. So and through the INSH, the Indian Society for Heart and Lung Transplant, we can give you authentic guidelines mentioned for the country, so that you can implement it and you can refer to INSH, the Indian Society for Heart and Lung, that India is, we can formulate according to our country. So
Right.
yeah.
So with this, we thank you very much, sir, and have a pleasant stay and safe return.
Okay.
Yeah. So
thank you very much, sir.
Thank you,
Thanks for
doctor.
listening to me. And I think it's a great step if we make guidelines to, at least few of the patients can be, even if few patients can be, because this is going to be at some point a common thing.
Right.
So
thank you very much. And with this, we thank you for sparing your valuable time. And now our second speaker is our own Vice President of AUSD, Dr. Rajiv Kumar Jain, sir. And Dr. Rajiv Kumar Jain is a senior consultant in Indian Railways, and he has been guiding us during this COVID times. And for last 1.5 years, we had been discussing how the pandemic is evolving, and he has got his great experience of 40 years in the hospital and health administration, and he is also a fellow of AUSD and published and presented more than 1.45 scientific papers and fellowships and scholarships by WHO, National Institute of Health, USA, and Canadian Society for International Health and International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. So may I request Dr. Rajiv Kumar Jain, sir, to start his deliberations with the COVID Epid updates, how we are through the pandemic, and whether the third wave is evolving. That we have to listen from Dr. Rajiv Kumar Jain, sir.
Thank you, Dr. Sandeep. Good evening, friends. Here we are again on a Saturday after a talk by Dr. Krishan on heart failure and how to salvage life. But COVID-19 is about life and livelihoods. And unless we understand the epidemiology of this pandemic, we would not be prepared to manage the lives and the livelihoods, which is much more basic for everybody on earth today, because this is a pandemic of unparalleled proportions. Let's see what is the epidemiological situation of COVID-19. Let's look at the global situation first. With over 4.5 million new cases reported, the number of new cases globally seems to be stable after increasing for nearly 2 months, that is since mid-June. The regions of Western Pacific and Americas continue to report increases in new cases, with increases of 20% and 8% respectively as compared to last week. The Southeast Asia and Eastern Mediterranean regions reported decreases in weekly incidence of 16% and 10% respectively. The European and African regions reported case incidence rates similar to those reported last week. So 2 regions increased, 2 regions decreased, and 2 regions same. The number of deaths reported globally this week remains similar to last week, with over 68,000 new deaths reported. 2 regions, including Europe and Americas, reported increases in new deaths of 11% and 10% respectively. The African and Southeast Asia region reported decreases in the new deaths of 11% and 10% respectively, whereas the numbers of deaths reported in the Eastern Mediterranean and Western Pacific regions were similar to the numbers reported last week. The cumulative number of cases reported globally is now over 211 million, and the cumulative number of deaths is just over 4.4 million. And you see the graph, the global graph of cases and deaths in the graph below. And you see the regions shown in different colors. Americas being yellow, Southeast Asia being violet, Europe green, and Eastern Mediterranean dark green, Africa blue, Western Pacific purple, and deaths in black line. So you're seeing the trend, the trend, how things are changing, are going down and going up in waves and waves. Let's go much more substantive data in numbers. This is the position of new cases in last 7 days and changes in new cases in last 7 days. As I told you, 8% and 20% in Western Pacific and Americas, and -16, -10 in South Asia, Eastern Mediterranean, Europe 0, and Africa -3. In new deaths, as I told you, overall only 1% increase, but 10 to 11% increase in Americas and Europe, and -10 in Southeast Asia, 1% Eastern Mediterranean, 3% Western Pacific. Africa -11%. Let's see the next slide. This is the COVID-19 situation as on day today, just half an hour before the start of this session. In the last 7 days, 45 lakh cases have been reported globally. Out of these, 16 lakh were in Americas, and Europe had 11 lakh 86,000, Southeast Asia 5 lakh 55,000, Eastern Mediterranean 4 lakh 20,000, Western Pacific 5 lakh 47,000, Africa 1 lakh 53,000. Let's see the condition of the nations now. This is the ranking of the countries from the top to next 10 top countries in terms of cases newly reported in the last 7 days. Out of 45 lakh cases, the United States alone reported 10 lakh 73,000 cases, the highest country reporting the highest number of cases. After United States of America, it is Iran, the Islamic Republic of Iran, which reported 2 lakh 45,000 cases. India reported 2 lakh 44,000 cases. United Kingdom reported 2 lakh 36,000 cases. Brazil 1 lakh 87,000 cases. Japan 1 lakh 61,000. Malaysia 1 lakh 51,000. Russian Federation 1 lakh 38,000. Turkey 1 lakh 35,000. And Thailand 1 lakh 29,000. So what do you see? Again, new countries are in the top 10. Malaysia, Turkey, Thailand are in the top 10. And you see Islamic Republic of Iran is maintaining its second position week after week. Let's see the position in terms of deaths during this last 7 days. This is the ranking of the countries in terms of deaths newly reported in the last 7 days. Out of 67,000 deaths reported globally, 8,000 were reported from United States. Indonesia reported 6,200, Russian Federation 5,556, Mexico 4,900, Brazil 4,900, Iran reported 4,400, India 3,272, Vietnam 2,500, South Africa 2,100, and Philippines to 1,800. So you find a very wide variation and dynamic figure in terms of deaths as on date. Let's go further and see the Southeast Asia region now. The Southeast East Asia region, where India is situated, reported 6,14,000 new cases this week. which is a 16% decrease as compared to the previous week, and the largest proportion decrease across all 6 WHO regions. All countries in the region reported a decrease in the number of weekly cases, except for Maldives, Sri Lanka, and Timor-Leste, where the number of new cases increased by 6%, 40%, and 59% respectively. This week, the region reported 17,000 new deaths, a 10% decrease respectively compared to the previous week, although half of the countries, that is 50%, continue to report increases. The highest number of new cases were reported from India, that is 231,000 new cases, which is 10% decrease. Thailand, 142,000 cases, which is 6% decrease. And Indonesia, 125,000 cases with 34% decrease. The highest number of new deaths were reported from Indonesia, 8,784 with 16% decrease. India, 3,100 deaths, 7% decrease. And Thailand, 1,768 new deaths, but a 31% increase. So you see a diverse picture still across Southeast Asia region. Now, let's come to India. But before we come to India, let's review the variants of concern. The current data indicates that Delta variant shows increased transmissibility and secondary attack rate and similar transmissibility between vaccinated and unvaccinated individuals. Delta variant also shows increased risk of hospitalization. Delta variant also shows reduction in neutralizing activity. Also, there has been no change in the impact on diagnostics on Delta variant. Next slide, please. This is the global distribution of the variants of concern. Alpha is now in 192 countries. Beta is in 141 countries. Gamma is in 86 countries. And look at Delta. Delta is now in 163 countries. And India continues to have presence of all 4 variants of concern. And Delta variant is spreading faster than any other variant of concern. Next slide, please. This is the COVID-19 India snapshot. 46,798 new cases in the last 24 hours, 514 deaths, and 17.6 lakh tests yesterday. 70% of reported cases came from Kerala yesterday. 7-day average test positivity has been 2.2%. 3.5 lakh active cases are there. Total 3.26 crore cases. 4,37,403 deaths have reported. And another new landmark. We have crossed 62 crore vaccination doses. And yesterday was another milestone with 1 crore doses of vaccination given in a single day. Next slide, please. This is the new COVID cases, deaths, tests, and test positivity rate and growth rates as on date. As you see on the left column, the confirmed cases out of 46,000 cases, Kerala reported 32,000 cases, Maharashtra 4,600, Tamil Nadu 1,500, Andhra Pradesh 1,550, Karnataka 1,301. And deaths, Kerala reported 179 out of 514 deaths, and Maharashtra reported 170 deaths out of 514. Odisha 69, Tamil Nadu 21 deaths, Karnataka 17 deaths, Andhra Pradesh 10 deaths. So you find South India, Western India, Eastern India continuing to show number of deaths. If you look at tests per million per day, Indian average is 1,293, Rajasthan 387, West Bengal 443, Chhattisgarh 652, Madhya Pradesh 656, 856, Meghalaya 931. So these states are still testing much lower test per million per day. If you look at test 7-day average test positivity rate, Indian, as I told you earlier, 2.2%. Chandigarh has got 20.6% test positivity rate, Kerala 17.7%, Manipur 11.4%, Mizoram 9.2%, Meghalaya 9%, Sikkim 8.7%. So these are the states which are showing very, very high test positivity rate as on date. If you look at the 7-day average daily growth, the Indian average is 0.11%, Mizoram is 1.29%, Chandigarh is 0.7%, Kerala is 0.59%, Meghalaya 0.36%, Manipur 0.33%, Sikkim 0.23%. So these are the states which are showing very high daily average growth rate during the last 7 days. If you look at the vaccinated persons with at least one dose in percentage, total India, 35.34% have received the vaccination one dose, but Bihar only 23%, 25%, 8%, Nagaland 29%. So these are the states which needs to still increase the pace of vaccinations with at least one dose in their states. Next slide, please. This is the chart showing percentage of eligible population, that is 18 plus, vaccinated with at least one dose is 50.3%. Highest is in Himachal Pradesh, 97.7%. Lowest is in West Bengal with 37.7%. So top red states are West Bengal, Uttar Pradesh, Bihar, Jharkhand, Tamil Nadu, Punjab, Maharashtra, Telangana, Chhattisgarh, and then we have India, the bottom red column. And blue states are, look at the variation from Himachal Pradesh to West Bengal. So there, this inequity in percentage of vaccinated individuals with at least one dose needs to be bridged. Next slide, please. This is percentage of eligible population fully vaccinated. If you look at the position, Himachal Pradesh is showing more than 30%, while Indian average is 14.69%. West Bengal 14.67, Madhya Pradesh 13.9, Punjab 13.6, Assam 12.3, Tamil Nadu 10.2, Jharkhand 9.8, Bihar 7.7, Uttar Pradesh 7.2. These are the percentage of population fully vaccinated. So they have to again continue to ramp up their vaccination process. Next slide, please. This is the graph showing the trend. The total doses administered. First dose is 47 crore and second dose 13 crore 81 lakh. And look at the trend, how things are changing. The first dose is in red, second dose is in blue, total dose is in yellow. Next slide, please. We find that these are the 20 districts farthest from their targets. This is, you find, which are Assam in Senapati district, Telangana, Mehbubnagar, northeastern states of Assam, Ukrul, northeastern states without Assam, Take, northeastern state Tunsang, northeastern states in Tefir, then Kurungkume, Wokha, Tamenglong, and Zuboto. Then you have Peren, then you have Khobol, and you have Mon, and you have Narayanpur, and then Mokchung, Purulia in West Bengal, Adilabad in Telangana, Sarguja in Chhattisgarh, Jangir in Chhattisgarh, then Assam, Lower Subarnrekha, and these are the districts showing very less vaccinations. They need to bridge their gap in vaccination. They will miss the targets otherwise. Next slide, please. This is the graph showing gender inequality in vaccinations. Wherever blue is there, that is a good trend, that male-female ratio has been reasonably good, but the whole graph is full of yellow. That means more males are getting vaccinated. The farther, the thicker the graph, more males than females. That is the disturbing trend. More women equally have to be vaccinated, and we need to have equity and equality in gender in vaccinations. Next slide, please. Delhi schools are reopening next week. Class 6 under no reopening yet. Class 6 to 8 on September 8, and class 9 to 12 from September 1. So while no final decision has been taken regarding junior classes, there will be a staggered restarting of classes across the capital. Online classes are no substitute. The kind of education that can be imparted through physical classes can never be substituted by online classes. So we have decided to allow schools to open. That is what Mr. Manish Sisodia, Deputy Chief Minister of Delhi, told. Parents' consent is mandatory. No student can be forced to attend physical classes online classes will continue too. Recommended SOPs are separate entry and exit to avoid crowding, 50% attendance, availability of quarantine centers, and random tests for students and staff. 10 states have already started staggered classes for school students. These include Chandigarh, Chhattisgarh, Jharkhand, Karnataka, Madhya Pradesh, Mizoram, Nagaland, Odisha, Punjab, and Uttarakhand. 98% of teaching, non-teaching staff have taken at least one dose of the vaccine. So again, lives and livelihood, life has to go on. And this is a new beginning where Delhi has been reporting less than 0.1% test positivity rate for the last many weeks. Next slide, please. Now we see another issue, that is Covaxin ramp up is vital to India meet India's vaccine goal. India has fully vaccinated 10% of its population and partially vaccinated 34% of its population so far. 525 million Covishield doses and 73 million Covaxin doses have been administered. Both Serum Institute of India, which produces Covishield, and Bharat Biotech, which produces Covaxin, have raised production. However, unlike Serum Institute of India, which has been able to raise Covishield supplies significantly, Bharat Biotech has lagged behind. Monthly vaccination data shows that supply of both vaccines have gone up. However, Covishield supplies have increased more, going up from 49 million in May to about 100 million a month now. In comparison, Covaxin supplies have moved up from 9 million to 15 million. Covishield supply has been in line with common expectations, mainly because of the export ban in May. But Covaxin has fallen short. In April, the comment said the monthly production capacity of Covaxin was 10 million doses, set to double to 20 million by May. However, its average supply in the last 3 months has been only 3/4 of that. This has in turn impacted the speed of India's vaccination drive. Government claims about Covaxin distribution continue to remain optimistic, but the distribution data tells a different story. Earlier this month, India's health ministry informed Parliament that Covaxin's monthly capacity was 25 million in July and set to reach 58 million in August. However, only 15.1 million doses were distributed in July and 18.3 million so far in August. The ramp up over the next 5 months will depend on whether its new production units in Bangalore and Ankleshwar can deliver. Next slide, please. This is the situation of vaccine supply, monthly production, which the target was 20 to 58 million. Covaxin is in gray and Covishield is in red. And Himachal Pradesh and Kerala lead the vaccination amongst major states. Himachal Pradesh is showing vaccines 943 doses given per 1,000 population, and Kerala again is in the red, more than 750 doses for every 1,000. Tripura is again leading, and Maharashtra is only 446, Gujarat is only 689, while Tamil Nadu is very low at 383 per 1,000 population. Next slide, please. If you look at the position of weekly change in COVID-19 vaccine doses per 100 people in percentage and the cumulative COVID-19 vaccination per 100 people globally, Bangladesh has reclaimed top spot in weekly growth in vaccine coverage. Several of India's Asian peers, such as Bangladesh and the Philippines, are ramping up vaccine production fast. Bangladesh surpassed the Philippines to reclaim its top position among the most populous countries in weekly increase in vaccination coverage over the past week. The Bangladeshi government has signed a memorandum of understanding with China's Sinopharm and Bangladesh Incepta vaccines. This would enable the Bangladeshi vaccine manufacturer to produce 5 million export quality Sinopharm vaccine doses per month. Japan also ramped up its vaccination coverage significantly, mostly because of the resumption of the AstraZeneca vaccine that it has stopped using in May because of concerns over blood clots. As advanced economies prioritize booster shots in their own countries, supply snacks could again crop up. The World Health Organization chief called for a 2-month moratorium on booster doses, but it is likely to go unheeded. Next slide, please. Here is a graph showing a map showing 5 districts, all from Kerala, which are reporting more than 10,000 weekly cases. Kozhikode 15,000, Malappuram 15,800, Palghat 11,000, Thrissur 15,600, and Ernakulam 15,008. 89. A silver lining for India is that reported cases have continued to decline at a national level. Over the past week, cases declined by 4%, and in the week prior to that, cases fell by 8%. All states and union territories saw a decline in cases over the past week, except Chandigarh, Delhi, Jammu Kashmir, Kerala, and Mizoram. Kerala, which hit the headlines for the highest one-day count in 3 months on 25th of August, has seen its cases rise by 2%. Chandigarh and Delhi undertook reconciliation exercises, which led to the rise in tally. Chandigarh added 3,034 cases in 22nd August, and Delhi added 150 cases on 24th August. Jammu and Kashmir reported an 8.4% increase in cases, with 8 of its 20 districts reporting an increase on a low base. Anantnag saw the sharpest rise, as cases this week jumped by 1.6 times over the last week. Mizoram reported an increase of 13.1%, with most cases in Aizawl, that is the capital of Mizoram. Next slide, please. Maharashtra's death toll saw a steady increase over the past week. The number of deaths also continues to decline week on week. The total toll this week was 3,317. 5 states reported more than 100 deaths. However, 3 of them, that is Karnataka, Kerala, and Tamil Nadu, registered a drop in deaths over the past week. In the other 2, that is Odisha and Maharashtra, it grew by less than 5% each. Among districts, Raigad and Palghar in Maharashtra, which saw a sudden incline in deaths last week, reported lower deaths. Raigad reported 43 deaths this week, down from 106 last week. Palghar reported 11 deaths this week, down from 54. Satara, Pune, and Nagpur saw the sharpest increase. Deaths in Satara and Pune this week jumped 2 times from last week. Nagpur reported 30 deaths this week from just 1 last week. As cases and deaths ebb, the pressure on government to ease mobility restrictions and reopen schools will only rise. However, without adequate safety protocols, crowding could lead to a flare-up in cases once again, as some pockets of the country are experiencing at the moment. Let's take up another issue now. That is the Kerala, the southern factor in India's COVID numbers. India has faced a brutal second wave of COVID-19 starting February that ran through the country till May. When this wave peaked on May 9, daily new cases fell sharply almost throughout India. However, in recent weeks, a growing outbreak in Kerala, apparently sparked by Onam festivities, has again started dominating headlines. On Wednesday this week, the state reported 31,445 new infections, making it responsible for more than 2/3 of all new cases reported across India on that day. The state's tally on Wednesday was also the most infections lodged in any state in India in a single day since May 27, when Tamil Nadu recorded 30,361 new cases. It is a given that Kerala, of course, is a region reporting the highest number of new cases. But if we look at big states seeing high number of cases with respect to their population, we see others on the list are largely located in southern India. After Kerala, that is 561 cases per million in the past week. On the list lie Maharashtra, 37 cases per million, followed by Andhra Pradesh, 25, Tamil Nadu, 22, Odisha, 20, Karnataka, 20, and Telangana, 9. We will show you 5 charts that try to show you how the post-second wave battle against the disease has weighed heavily on southern India and Maharashtra. Next slide, please. There's a first graph which shows you weekly average of new cases and deaths per million population in India. New cases per million is in blue, while new deaths per million is in red. The 7-day average of daily new cases in India has risen from 156-day low of 24 infections per million for the week ending Sunday to 25.3 for the week ending Wednesday. While this may only be a 5% increase and is heavily influenced by numbers from Kerala, it remains a cause of concern. In the same period, the 7 average of reported deaths across the week has seen an increase of 10%. If we look at per million population, and while the death trajectory has been sudden spurts since June due to states such as Maharashtra and Bihar adding deaths to their tallies that had earlier gone unreported, the recent spurt is not due to any major death toll reconciliation. All figures used in this analysis have been normalized using the region's population, as it provides a common comparison point for areas vastly different in size and population. Next slide, please. Kerala is contributing 58% of India's new cases. Weekly average new cases per million in Kerala and rest of India. Kerala is in purple and rest of India is in blue. More than 58% of new infections reported across the country in the past week can be traced back to just Kerala, a statistic that underscores how large an outlier the state is to the overall trend. With population factored in, Kerala has reported 561 new cases per million in the past week against a national average of around 25. But when Kerala's numbers are removed from the national tally, the latter sees a massive drop. There have been an average of around 11 new infections per million every day in the past week in the rest of India. Another way to look at these numbers is that per capita, Kerala is currently reporting 52 times as many new cases in the past week as the rest of the country. That is the way to look at the data more methodically and systematically. Next slide, please. But Kerala's share in the deaths is still not as bad. Weekly average deaths per million in Kerala and rest of India. If you look at Kerala is in dark red or brown and rest of India is in blue. When the same calculations are applied to the number of deaths reported due to COVID-19 in the past week, Kerala's numbers, though still high, see a marginal improvement. The state has been responsible for 35% of all deaths reported across India in the past week, a much lower share than its caseload. With population factored in, the state has seen 3.8 deaths per million residents against a national average of around 0.4 fatalities per million. Even removing Kerala's numbers from the national tally to derive the rest of India number doesn't improve the national figure by much. It only drops to 0.3 deaths per million. To be sure, it still implies that Kerala is currently reporting 14 times as many deaths due to COVID as the rest of the country. This is not surprising, as Kerala, despite its recent surge in infections, remains a region with one of the best case fatality rates in the country, that is 0.5 against a national average of 1.3%. Next slide. This is 6 regions seeing 16 times as many cases than the rest of the country. The graph shows weekly average new cases per million in 6 states against the rest of India. The 6 states are Maharashtra, Andhra Pradesh, Tamil Nadu, Telangana, Kerala, and Karnataka in red, and rest of India in blue. While the numbers of Maharashtra and 5 states from southern India, Andhra Pradesh, Tamil Nadu, Telangana, Kerala, and Karnataka are taken together, we see that the average new cases per million residents in these regions have grown 7%, from 76.8 to 81.9 in the past 4 days, against a national average of a 5% increase, as stated above. Together, these 6 states have reported 16 times as many cases as the rest of India, excluding these regions, where there have been just 5 new cases per million residents every day in the past week. Importantly, numbers in the rest of the country have not been rising as drastically in the past few days as much as they have been in the rest of the country, as can be seen in the chart very obviously. Next slide, please. This is the last slide in this series with slightly better performance on deaths. Weekly average deaths per million in 6 states against the rest of India. 6 states, Maharashtra, Andhra Pradesh, Tamil Nadu, Telangana, Kerala, and Karnataka in red, and rest of India in blue. The death trend in these 6 regions again presents a slightly better grasp of how they have managed to keep fatalities relatively low. Despite having reported 16 times as many cases as the rest of India in the past week, these states have seen 9 times as many fatalities as the rest of the country. On average, these 6 states have seen 1 death per million residents against 0.1 fatality per million in the rest of the country. A fact worthy of note here is that these regions are only getting better. On 1st of June, these regions were seeing an average of 5.9 fatalities every day for every million residents, 4.6 more than the rest of the country at the time, where there were 1.3 deaths per million. This gap has almost steadily improved and has now been reduced to 0.9 deaths per million in the past week. So we see a better interpretation of the data and better understanding of the situation on the ground. Let's see the last slide in the series. This is a statement by Dr. Soumya Swaminathan, Chief Scientist WHO. During the week, she said, we may be entering some kind of stage of endemicity where there is low level transmission or moderate level transmission going on, but we are not seeing the kinds of exponential growth and peaks that we saw a few months ago. And this is very, very important statement from the chief scientist of the World Health Organization. Another important statement from the chief scientist, Dr. Soumya Swaminathan, during the week. I will show you through a video which will be played now. Shivang, just play the video that I gave you. Yes.
I think what I would like to emphasize is that the WHO's position on boosters is based primarily on the scientific data that we are seeing. And then, of course, there's also the moral and ethical argument, which is clearly telling us that people around the world need a primary course of vaccination. Our urgent task today is to reduce and prevent mortality. We have the tools, we have the vaccines. We should not have 10,000 people dying every day due to COVID. But on the science side, which we are tracking very closely, and we recently had an expert group meeting with scientists from around the world. This included researchers, it included regulatory experts from different regulatory agencies. There was consensus that there is no, that the data around the need for boosters is not conclusive. It is true that we need to follow very carefully the vaccine efficacy and effectiveness over a period of time, because it is possible that some groups, the elderly, might need boosters at some point of time. It's possible that with different vaccines behave differently from each other in terms of the breadth and duration of protection. And it's also possible that with the new variants that you might need a booster strategy at some point. But putting together all of the evidence from all of the countries around the world, we are not at that point to recommend boosters. So I think that's the first point. The second point, of course, is that we have limited supplies of vaccines globally. We do not have unlimited supplies at this point of time. And therefore, those supplies need to go to the people who are desperately waiting for the vaccines, the frontline workers, the doctors and nurses who are still fighting this pandemic and who are losing their lives because they don't have access to the vaccine, and the elderly and the vulnerable. So we need to prioritize that. And as the Director General has said, we've called for a time-limited moratorium on the boosters so that we can get every country vaccinating at least 10% of their population by the end of September. So we have only a month, and 40% of populations by the end of the year. That will reduce mortality significantly. And then, of course, we can scale up vaccination. And by then, there will be data on boosters. We also don't know about the safety of boosters, because when we talk about vaccines, it's not just the efficacy. What happens when you give a third dose of an mRNA vaccine or any other kind of vaccine? These need to be studied as well. So before we launch into full-scale booster programs for the whole population, there are a number of questions that need to be answered. And maybe Kate wants to add to that. Thanks.
Thank you. That is what I wanted to share today. And epidemiology is a never-ending subject. But COVID-19 for this week, I think this should be enough and we will meet again next week to update again about the COVID-19 epidemiological situation for the next week. Thank you so much for your patient listening.
Thank you, Dr. Rajiv Jain, sir. So still we are amidst the pandemic, and the vaccines now they are in sufficient supplies in India, and daily about 70-80 lakhs vaccinations are being given, and soon we will be able to vaccinate our whole population. Dr. Gajen Kumar sir has raised his hand, so we may have some questions from Dr.
First of all, I congratulate Dr. Rajiv Kumar for such a detailed presentation on the subject, and very, very interestingly, he has put forth all the points. Now coming to my questions, I have two questions to ask. Number one question is, as the system is opening up, as for the revival of the economy, the people are going to the work, the schools are now opening up, the festival season is coming. one of the recommendation for prevention of COVID, that is social distancing. It is totally impractical in a country like India, which is highly and densely populated country. On the contrary, a very simple measure of wearing a mask properly is a far more easily implementable and effective method to control the spread of the disease. So I need the remarks of the speaker. Can we drop this social distancing point from the preventive strategies, because it is 100% impractical while in the schools or the workplace or the marketplaces, or while traveling in an aircraft or a bus or a train, or in the coming festive season. This is my first question, because there is no point putting in energies for a implementation for a factor which we know we cannot implement. On the contrary, if we are very much focused about asking people to wear masks properly, that will go a long way, because now, because of this complacency, even in the hospital, I find people they are hanging their mask in the neck and they are roaming about feeling that they are wearing the mask, which indeed they are not. This is my first question. And my second question is, see, we have approved 5 or 6 vaccines in the country, but except these 2 vaccines, Covishield and Covaxin, I don't know where the other vaccines are. I have not seen anywhere the other vaccines are being used. So unless we rope in all the vaccines which we have approved, how we are going to achieve this target of immunization of even 40% of the population by end of the year, as recommended by the WHO chief scientist? These are my 2 questions.
Thank you so much for asking very relevant questions, and both the questions are worth pondering over. First, regarding social distancing, yes, one cannot re-emphasize that social distancing norms need to be met and monitored very effectively on the ground wherever they occur, whether it is in Uttar Pradesh or in Kerala. The risk remains, and risk also remains of new variants of concern emerging. The mutations are a real risk, because of simple reason that vaccination proportion of people who are vaccinated or normally infected is not very high in any population, even in Kerala, where vaccination rates are very high. So one need to have better implementation on the ground. Whatever be the shortcomings, they need to be overcome through people's participation, through effective communication, and very aggressive campaigning and punitive measures, if required, should be imposed. That is part one. Second, regarding vaccine doses, yes, the trend, that the expectation that Government of India had was derailed to some extent because of the problem with Ankleshwar plant and Bangalore plant of Covaxin. The samples that they were tested from these 2 plants, they could not come up to the standard that was set earlier for the main plant. So now the things are getting better, for at least for the Bangalore plant. For Ankleshwar plant, yes, it will take another 2-3 weeks, and then Covaxin production will be on track. So there was some delay. Regarding Zycov-D, yes, Zycov-D is going to come up, and that will come up in a big way sometime in October, November, but really effectively from January 22 onwards. The conversation or the engagement with international manufacturers of the vaccines, which do not have manufacturing plant in India, is stuck on issue of indemnity, because many companies are insisting indemnifying those companies for harm or damage caused outside India as well. So these are very complex issues, and that will continue. And in any case, other countries where the manufacturers' plants are there, they are not allowing exports by and large. Yeah, as you know, the situation in US is still very patchy. There are huge areas in US which still have to get vaccinations. So the US government is not promoting export of vaccines as a strategy in the long term, and most of the production plants are in US. Even you saw the Bangladeshi aggression in vaccination. They also took help of China, and now they have Sinopharm. But they have their own limitations, how effective it is, and what is the efficacy on the ground, that remains to be examined. So there are issues for and against scaling up. Scaling up with 2 vaccines which have shown very efficacious results on the ground in trial and in actual real situation. I think that's a better strategy. Production plants are all in India, and then scaling up those plants. Now Covaxin 3 plants and Serum Institute 2 plants have really able to deliver. So such a vast scale in India, it's unparalleled that this vaccine were developed in India and they are being manufactured in India. They are being administered in India. That's a huge cost saving. I think that strategy, if replicated faster, will bear more fruit than exploring more options for the vaccines.
What happened to Sputnik V? What happened to that?
Sputnik V has its own limitation. The production will come up sometime in October, November. The plants are processing their quality data methods at the moment. The agreement is in place, and Sputnik V may become available to a great extent, more likely in November 21 this year.
Okay. Thank you.
Thank you, Dr. Rajiv sir. So any other question from the panelists? If you have, you can unmute yourself and you can ask. Else we can conclude the session, because it's almost more than 1.5 hours.
Yes.
So it was a great session with a lot of insight about the medical circulatory devices, how they have come up in the rescue of the patient who really require them. They can increase the life, they can increase the quality of life, and yes, the cost is very high, but if they are provided to the right person, then the cost doesn't matter in front of the life and the quality of life which they provide. And as they have told that it has this ECMO and other things, they have helped a lot during this COVID times. And still we are not sure, as Dr. Rajiv Jain sir has told, that still we are amidst the pandemic, and still we are not out of the pandemic, and we need to have our finger crossed till everything subsides, till everyone is vaccinated. And yes sir, the question which you have raised is very valid, that we should better focus more on the proper wearing of the mask rather than social distancing. Although social distancing can't be dropped, wherever it is practicable, it should be practiced. But proper use of mask, that is very important. And that as a community fellow, we have to tell everyone, even to our near and dear ones, and the people whom we meet, wherever we meet, we should not feel shy in telling them what is the proper technique to use the mask, so that your nose and your oral mouth is covered, and at least we can say that they will be saved. If they don't understand the other language, that you may be spreading the infection, but we can always convince them that you can be safe. You won't be inhaling the virus which is there in the surrounding atmosphere. Then they will better understand. So as a medical person, we would definitely like to tell our fellow colleagues. And now our management people, they are also very much like focused on proper wearing of mask. Even I've seen during the virtual meetings, if some people, they used to wear the mask on their chins, then our directors, chairman, even they ask him either to take off the mask or don't use the mask, or use it, or put it properly. So with this, sir, we come to a conclusion of this today's important webinar. and it is the 66th webinar, and definitely we are doing a great job for the service of our young industrial physicians. And thanks to all the participants also for sparing their valuable time, and the learned speakers who prepare for the learnings to every one of us, and they meticulously they explain everything and answer all our queries. So with this, sir, I thank you all the participants, all the panelists, and all the
And
speakers.
a request that
Yeah.
on YouTube channel,
Yes.
the recorded video will be available, and people should comment, like, share, and in their network, so that other people can watch the deliberations of this webinar when they like, at their convenience. YouTube channel of Enoch DigiConnect chat platform.
Thank you. Thank
Yeah,
you all. Good night.
as Dr. Rajiv sir told, Enoch DigiConnect is a great repository which we are creating, and that is very useful, sir. We can because now we have thumbnailed the topics also of the various sessions. So whichever topic you want to refer to, you can easily see and spare some time and get all the knowledge out from there. So thank you all very much, sir. Thank you.
Thank you.
Thank you.